Welcome to the deep dive. Today, we're really rolling up our sleeves for an ambitious journey.
We are. We're tackling two incredibly complex areas in medicine.
Yeah, areas where getting the right diagnosis is, well, it's like high-level detective work.
Absolutely. And we're using a fantastic set of listener-provided source materials, definitions, pathways, the works.
Our goal here isn't just to cover the basics. It's to really get you, the listener, to a place where you feel you understand this material deeply.
Right, aiming for that professional level insight. We want to help you master this information.
We'll be digging into, first, the challenging world of fevers of unknown origin FUO.
That elusive fever.
And then we'll shift gears to the crucial evaluation of syncope, or fainting, how to approach that.
Both really fascinating, complex topics.
They are. And we're going to unpack the core insights from these detailed sources, guiding you through so you feel genuinely equipped, almost like you've navigated these scenarios yourself.
Think of it as accelerating that learning curve, getting you to grips with complex info faster.
Exactly. So let's start with those favors that just won't reveal their source, FUO.
Okay, FUO. So we often hear fever without an obvious cause, right? Kind of a general term. But fever of unknown origin, FUO, that has a very precise definition according to our sources. Getting this definition down is step one.
Absolutely essential. So pulling from the material, what are the criteria? It starts with the fever itself.
Right. It has to be at least 38.3 degrees Celsius. That's 101 Fahrenheit.
And not just once, right?
No, documented on at least two separate occasions. And the illness needs to have been going on for 3 weeks or longer.
3 weeks minimum. And crucially, the patient isn't known to be immunocompromised.
That's a key point. No known immunocompromised state, because that changes the whole diagnostic picture.
Okay, so fever, duration, immunocompetence. What makes it unknown origin?
This is the clincher. The diagnosis has to still be uncertain after a really thorough workup.
Not just any workup.
No. A full history, a detailed physical exam, and a specific list of what the sources call obligatory investigations. If you've done all that and you still don't know why, then it's FUO.
That's quite different from how it started back in, 1961?
Yeah, the original Petersdorf and Beeson definition. That required a week of inpatient evaluation.
And the sources say that changed because, medicine changed.
Exactly. Patients aren't always admitted just for diagnosis anymore. And separating out immunocompromised patients makes sense diagnostically.
Plus, specifying the tests rather than just time makes it more standardized, doesn't it?
It does. Standardizes the baseline workup before you call it FUO.
The sources also mention something related IUO, inflammation of unknown origin.
Right, IUO. Very similar concept. Same duration, 3 weeks plus. Same immunocompetence requirement. Same uncertainty after the obligatory tests.
But no fever.
Correct. Normal temperature, but they have elevated inflammatory markers like C-reactive protein, CRP, or erythrocyte sedimentation rate, ESR for those 3 weeks or more.
So it's the inflammation signal that's unexplained.
Precisely. And since the diagnostic approach is basically the same, the sources often just use FUO to cover both scenarios. It's about persistent, unexplained inflammation.
Got it. So it's a formal starting point for a diagnostic hunt. Once you know someone fits this FUO profile, what are you actually looking for? Have the causes changed much over time?
Oh, dramatically. The sources are really clear on this. What causes FUO today is quite different from decades ago.
Why the shift?
Several factors. Changes in how common certain diseases are. Obviously, antibiotic use has had an impact. But the big driver, new diagnostic technology.
Can you give some examples from the materials? How has tech changed things?
Sure. Think about intra-abdominal abscesses or certain tumors, or even infective endocarditis infection of the heart valves.
Those used to be big FUO culprits.
Significant ones, yes. But now with CT scans, ultrasound, much better blood cultures, echocardiograms, we often find these things much earlier.
Before they even meet the 3-week FUO criteria.
Exactly. They get diagnosed sooner. On the flip side, you have conditions like acute HIV infection, which wasn't even recognized as a possibility when FUO was first defined.
So we find the easier stuff faster, and new causes pop up. And the sources stress that geography matters too, right? Where you are in the world changes the odds.
Hugely important point. Table 20-1 in the sources really lays this out. In non-Western countries, infections are still the dominant cause.
Like TB.
Tuberculosis is a major player, yes. In some areas, Mycobacterium tuberculosis accounts for a huge chunk, sometimes up to half of FUO cases, especially where TB is prevalent. Middle East data, for instance, shows infections as the median cause in maybe 66% of cases.
And a lower rate of no diagnosis there, too.
Right, median around 8% remaining undiagnosed in that cohort.
But flip to Western cohorts, like Western Europe in the table.
It's a different picture. There, the most common category becomes non-infectious inflammatory diseases, NIDs.
Things like autoimmune conditions?
Yeah, exactly. Autoimmune diseases, autoinflammatory syndromes, vasculitis, those make up about 25% median in Western European data. Infections are still there, maybe 17% median, malignancy around 10%, miscellaneous 10%.
And that's where you see that much higher no diagnosis rate, median 37% in that data. Why such a big jump?
It comes back to those early advanced diagnostics. In Western settings, patients often get investigated sooner and more intensely with CT, MRI, maybe even PT-CT early on.
So the straightforward cases get picked off before they hit the FUO definition.
Precisely. What's left tends to be the really tricky, obscure stuff, which pushes up the proportion where, even after the full FUO workup, you don't find a specific label. Not necessarily that it's unknowable, just harder to find after standard routes failed.
And if you do end up in that no diagnosis category, is that worrying?
Actually, the sources offer some reassurance here. Generally, patients whose FUO remains unexplained tend to have a pretty good prognosis.
That's interesting.
Yeah, and if someone has recurrent fever episodes that remain undiagnosed, the chance of eventually finding a cause drops even lower, below 50%.
Okay, so definition is key. Causes vary. Sometimes you don't find an answer, but that's often okay. Now, the hunt itself, the list of potential causes is just huge.
It's vast. Table 22 lists reported causes, and it's almost overwhelming. Infections, NIIDs, cancers, miscellaneous. But there's a core principle the sources hammer home.
Which is?
FUO is much more likely to be an atypical presentation of a common disease than it is to be a genuinely rare condition. That's the guiding light.
Right. Think common things presenting uncommonly before chasing zebras. What are some examples from the sources of common stuff that pops up as FUO?
They mention atypical presentations of things like endocarditis, diverticulitis, vertebral osteomyelitis infection in the spine bones, and especially extrapulmonary tuberculosis, TB outside the lungs. These don't follow the textbook script, so they get missed initially.
And digging into those broad categories, infections first, any tricky ones highlighted?
Definitely. Q fever, for example. You'd think about that with, say, rural exposure history, or if the patient has issues with heart valves, aortic aneurysms, or vascular grafts, the bug likes those areas, needs specific blood tests, IFA serology.
Not standard cultures.
No. Then there's Trophorema whipli, the cause of Whipple's disease. If someone has FUO plus weird CNS, gut, or joint symptoms, you need that on your radar and need specific PCR testing.
And culture-negative endocarditis.
Yeah, that's endocarditis, where regular blood cultures are negative. Could be organisms that are just hard to grow. The fastidious ones like H.A.-Seq group, Coxiella burnetii Q fever, again T. whipli, Bartonella. Or it might not even be infectious, like non-bacterial thrombotic endocarditis in cancer patients or sterile vegetations in autoimmune diseases like lupus.
Really highlights the need for specific tests or thinking outside the box when standard stuff fails. What about the non-infectious inflammatory diseases, the NIDs?
The more common NIDs causing FUO include adult-onset Still's disease, large vessel vasculitis like giant cell arteritis, or polymyalgia rheumatica, systemic lupus, SLE, and sarcoidosis.
Any rare ones to keep in mind?
Most hereditary autoinflammatory syndromes are rare causes in adults, but familial Mediterranean fever, FMF, might be considered in people from specific high prevalence regions. Schnitzler syndrome is uncommon, but distinctive chronic hives, bone pain, a specific monoclonal gammopathy finding in the blood. Easier to suspect if you know the pattern.
And cancer neoplasms.
Lots of cancers can cause fever, but the sources single out malignant lymphoma as the most frequent neoplastic cause of FUO. And the fever can actually start before you can feel any swollen lymph nodes or see them clearly on scans.
Okay, and the miscellaneous bucket. Anything particularly important there?
Drug-induced fever, this is a big one. The sources warn any drug can potentially cause fever, even ones taken for a long time.
Even common ones.
Absolutely. And there's a severe form called Debre's syndrome drug reaction with eosinophilia and systemic symptoms. The list of common culprits is long. Sulfa drugs, minocycline, vancomycin, beta-lactams like penicillin, TB meds like isoniazid, gout meds like allopurinol, several anti-seizure drugs like carbamazepine, lamotrigine, phenytoin, also things like sulfasalazine, the diuretic furosemide, quinidine for heart rhythm, nevirapine for HIV, It's extensive.
Definitely something to revisit constantly. Any other miscellaneous causes?
Well, exercise-induced hyperthermia fever after exercise, but inflammation markers are normal, and crucially, the person is usually sweating, unlike in true fever where thermoregulation is off.
Oh, okay.
Then there's factitious fever, self-induced, maybe injecting something contaminated, more common in young women, sometimes in healthcare settings, and fraudulent fever manipulating the thermometer. Clues might be a normal temperature checked elsewhere or a pulse rate that just doesn't match the supposed high fever.
Important to consider those, though perhaps delicate to investigate. The sources also mentioned age affecting the likely causes.
Yes, definitely. In older patients, a cause is actually more likely to be found, and it's often, again, an atypical presentation of something common in that age group, especially giant cell arteritis and polymyalgia rheumatica. TB is also more common in elderly FUO compared to younger adults.
Right. Okay, that maps out the landscape of possibilities. How do you navigate this?
Yeah.
The sources outline a structured diagnostic approach.
And structure is key here. It's about being systematic. It starts with those baseline essentials: a really comprehensive history, a meticulous physical exam, and performing all those obligatory investigations we mentioned earlier.
And the most critical goal during this initial phase.
Finding potentially diagnostic clues, PDCs. Any sign, symptom, or abnormal result that points towards a specific organ system, location, or disease process. The sources emphasize this is the most important step.
Even if they might be misleading sometimes.
Even then, because they give you a direction, they help you target the next wave of tests, which are often more invasive or expensive, rather than just shooting in the dark.
So what areas need intense focus in that history and physical exam?
The history needs incredible detail. Fever pattern, exact duration, past illnesses, every medication, current and recent, family history, sexual history, place of birth, all travel history, not just recent trips, any unusual environmental exposures, hobbies, animal contacts. It's exhaustive.
And the physical.
Head to toe, very carefully. Eyes, lymph nodes everywhere, feeling the temporal arteries, particularly in older folks. Checking liver and spleen size, looking closely at skin, mucous membranes, any surgical scars. Meticulous.
And there's a crucial early step regarding medications the patient might be on.
Yes. Before launching into tons of tests, the sources strongly advise stopping or substituting any non-essential antibiotics and glucocorticoids, steroids.
Why is that so important?
Because they can really muddy the waters. They can suppress fever, mask inflammation, and make it impossible to grow bacteria in cultures, potentially hiding the actual diagnosis.
Okay, let's just quickly list those obligatory investigations again, since they were part of the definition.
Sure. It's ESR and CRP for inflammation, CBC with differential and platelets, electrolytes and creatinine for kidney function, total protein and protein electrophoresis, liver enzymes like alkaline phosphatase, AST, ALT plus LDH and creatine kinase, ferritin, ANA, and rheumatoid factor for autoimmune screening, urinalysis, 3 sets of blood cultures from different sites times, urine culture, a chest x-ray, an abdominal ultrasound, and a TB test, either the skin test, TST, or an IgRA blood test.
That's the essential starting toolkit. Then what? What guides the next steps?
It hinges on those PDCs. If you find clear PDCs, you follow those leads with targeted tests. If there are no PDCs, or the ones you found seem misleading, the next move isn't random testing.
What is it then?
It's about reassessment. Go back, repeat the history, repeat the physical exam, double-check drug exposures, consider factitious or fraudulent fever more closely, make sure interfering meds are stopped, and consider getting an ophthalmologist to do a fundoscopy to look at the back of the eye.
Before jumping to more advanced stuff, makes sense. What about the specific value of some tests mentioned? Ultrasound versus CT initially.
Ultrasound is preferred initially for the abdomen in that obligatory set, no radiation, lower cost, good screening tool. For other tests beyond the obligatory panel, like more esoteric blood tests, generally low yield without PDCs pointing you there, can get lots of false positives. Maybe cryoglobulins as a cheap screen, but otherwise be guided.
And microbiology, you mentioned 3 blood cultures?
Yes, 3 sets maximize yield. And tell the lab if you suspect hard-to-grow bugs like HA-seq, they need longer incubation. Special media if you suspect fungi like histoplasma or bacteria like Legionella. But doing more than 3 blood cultures or multiple urine cultures without specific reason, usually not helpful, and best drawn before antibiotics or within a week of stopping them.
CSF exam, if there's headache.
Absolutely necessary if FUO plus headache or neurological signs. Need to look for infections involving the brain or meninges, herpes, cryptococcus, TB meningitis. CSF patterns can give clues like high protein, low glucose, and TB.
And broad serology screens for infections.
Sources advise against shotgun serology testing without specific clues. Testograph for TB are obligatory, but remember they can be false negative if someone's very ill, malnourished, or immunosuppressed. IGRA avoids BCG interference, but sensitivity is similar to TST overall. Miliary TB, widespread TB, can be very hard to diagnose. Biopsies of liver, bone marrow, or lymph nodes might be needed if suspected.
What about other imaging like echo or sinus scans?
Low yield as routine screening. Echocardiogram for the heart, CT of sinuses, bronchoscopy for lungs. GI scopes reserve these for when there are specific symptoms or signs pointing to those areas. Don't just do them because you haven't found anything yet.
Okay, that systematic approach is really clear. Baseline tests, hunt for PDCs, follow clues. If no clues, reassess carefully. What if that whole first stage fails, but the patient still has fever or high inflammatory markers?
That's where advanced imaging often comes in. If the initial workup is negative and there's ongoing inflammation, the next logical step recommended by the sources is often FDG-PT-CT.
What exactly is that showing us in FUO?
Okay, so FDG is basically radioactive sugar. Cells that are working hard, metabolically active, gobble up more sugar. That includes cancer cells, but crucially, it also includes activated immune cells involved in infection and inflammation.
So the PT scan lights up these hotspots.
Exactly. It shows areas of high metabolic activity anywhere in the body. The CT part of the scan just provides the anatomical map showing where those hotspots are located.
What are the advantages of using it here?
It's got high resolution. It's often better than older scans at picking up chronic, low-grade infections, good for looking at the spine. And a key advantage highlighted in the sources, it can actually show increased activity within the walls of large blood vessels.
Suggesting vasculitis.
Precisely. It can be a major clue for large vessel vasculitis, like in the example figure showing uptake in inflamed arteries.
But it doesn't tell you why it's hot,
Yeah.
right? Infection, inflammation, cancer.
Correct. That's the main limitation. It sees metabolic activity, not the specific cause, so it can't reliably distinguish between those possibilities just based on the scan pattern.
So its value is localization.
Immense value in localization. It tells you where the problem likely is, guiding you to the right spot for a biopsy or targeted culture to get the definitive answer.
Are there interpretation challenges, things that look hot but aren't disease?
Yes, definitely. The brain always uses lots of glucose. The heart can too, though diet can reduce that. Bowel, kidneys, bladder show normal excretion. And cytokines from the fever itself can cause some non-specific uptake in the bone marrow. So careful interpretation is needed.
And timing. When should you do the PT-CT?
Ideally, during a febrile episode or when the inflammatory markers like CRP-SR are clearly elevated, that maximizes the chance of seeing the active process.
What's the diagnostic yield like?
Pretty good, actually.
Yeah.
Studies cited suggest PT-CT helps reach a diagnosis in around 50% of FUO cases where the initial workup failed. Sensitivity for finding an abnormal area is high, maybe 85%, but specificity for the exact cause is lower, around 50%, because it sees activity, not the cause itself.
Is it cost-effective? Seems expensive.
The argument is, yes, it can be, if used at the right time after the initial workup fails, but before endless other tests. By potentially leading to a faster diagnosis, it might reduce hospital stays and avoid a cascade of less useful investigations.
But repeating it isn't usually helpful.
Generally not, according to the sources, unless something clinically changes or new PDCs emerge.
What about the older scans? Gallium or tagged white blood cell scans?
They're mentioned as alternatives if PCT isn't available, but the sources clearly state they have lower sensitivity and specificity, so their diagnostic yield is considerably lower than PTT. Gallium, maybe 20-55%, leukocyte scans even lower, 8-31%.
Okay, so you've done the initial workup, maybe chased PDCs, done a PTT, which might have shown a spot, or maybe not. What if you still don't have answers?
This is where things get tougher, and you might consider later stage or more invasive tests, often guided by subtle hints from the imaging. If PT-CT did show a suspicious lymph node or skin lesion, you absolutely need a biopsy for histology and culture.
And if the PTT was negative or nonspecific, or biopsies didn't help?
Then the sources suggest considering some second-stage screening tests, but cautiously. Chest and abdominal CT scans might still find something in about 20% of cases, even after a PT-CT, and they're non-invasive.
Bone marrow biopsy.
Generally low yield without specific blood abnormalities or strong suspicion of hematologic malignancy or disseminated infection like miliary TB, and even less useful after a PT-CT has already looked for marrow involvement.
What about a temporal artery biopsy?
This one is specifically recommended for patients 55 or older if the diagnosis is still elusive, especially if there's any lingering suspicion of giant cell arteritis. Why? Because PTCT can sometimes miss inflammation just in those small temporal arteries due to resolution limits and brain activity nearby.
And liver biopsy used to be common.
Less so now as a routine FUO test. The risks bleeding, infection are significant, and the yield is low unless you have specific liver abnormalities or a high suspicion of miliary TB. Not recommended for general screening anymore.
So after all that baseline, PDCs, PECT, targeted biopsies, maybe second-stage screening if you still have no diagnosis, what then? Just keep testing.
Actually, the sources advise against that. At this point, the chance of finding something with more random tests is very low, but the cost and risk are high.
So what's the recommended path?
Often, the best strategy is to pause the aggressive testing. Go back again to the history and physical. Meticulously review all the results obtained so far, maybe get outside records, and then wait and watch for new PDCs to emerge. Diagnostic delays often happen because a subtle clue was missed early on.
Patience and watchful waiting, unless.
Unless the patient is clearly getting worse without new clues, then you might need to reconsider more aggressive steps. But otherwise, pause and reassess is often better than random further screening.
That takes discipline. What about getting a fresh pair of eyes on the case?
Absolutely recommended. The sources cite data showing the value of a second opinion at an expert center for unexplained FUO. One study found a diagnosis was made in over half the referred cases, 57%. And even more, nearly 70%, had a beneficial outcome, which sometimes included seeing how they responded to a carefully chosen empirical treatment.
Okay, let's talk treatment. There's a big warning in the sources about just trying treatments without a diagnosis, right? Empirical therapy.
A very strong caution. The advice is do not start empirical trials throwing antibiotics, steroids, or anti-TB drugs at it unless the patient is truly deteriorating rapidly and you've already done a comprehensive appropriate workup that hasn't yielded an answer.
Why be so cautious?
Because, as we touched on, these drugs can completely obscure the diagnosis. Antibiotics or anti-TB meds might stop you from ever culturing the bug. Steroids can suppress fever and inflammation from serious infections or cancers like lymphoma, making you miss the chance to diagnose and cure a potentially treatable condition. It masks the underlying problem.
So when is it considered okay to treat empirically?
The sources give specific scenarios. Empirical broad-spectrum antibiotics, if the patient is hemodynamically unstable, think septic shock, or profoundly neutropenic, meaning very low white blood cells. In those cases, the risk of overwhelming infection is immediate.
And anti-TB meds.
An empirical trial might be considered if TB tests, TS-AGRA, are positive, or if biopsy shows granulomas and the patient is anergic, doesn't react to skin tests. And other granulomatous diseases like sarcoidosis seem unlikely based on the whole picture.
Are there treatments where the response itself might give a clue?
Yes, a few are mentioned. Colchicine, for instance, is highly effective for attacks of familial Mediterranean fever, FMF. While a single-dose response isn't perfectly diagnostic, preventing future attacks with ongoing treatment strongly supports FMF. So trying it if FMF is suspected, especially in relevant populations, makes sense.
What about NSIs or steroids for clues?
NSAIDs are mainly for symptom relief, but the sources note a dramatic response can sometimes be seen in adult-onset Still's disease, which can be a hint. Glucocorticoids, steroids, have profound effects in conditions like giant cell arteritis and polymyalgia rheumatica. But again, that huge caution. Using them empirically early on is dangerous because they mask infection and lymphoma so well. Avoid unless infection lymphoma seem very unlikely and a severe inflammatory disease is strongly suspected.
Any newer, more targeted therapies mentioned?
Yes, interleukin-1, IL-1 inhibitors, specifically anakinra. IL-1 is a key driver of fever and inflammation. Blocking it with anakinra can be incredibly effective, often rapidly, for many autoinflammatory syndromes. The sources list FMF, CPS, Charcot-Etch, ADs, Schnitzler, Still's disease.
So that could be an option later on.
It could be considered for undiagnosed FUO after extensive workup, especially if an autoinflammatory condition is suspected but unproven. A big plus is controlling symptoms without the major side effects of long-term steroids.
So after this exhaustive process, some cases remain unexplained. What's the long-term outlook for those patients?
Generally quite good, surprisingly. For patients whose FUO remains undiagnosed despite a thorough evaluation, the prognosis is usually favorable. The studies cited show low mortality rates over follow-up. One study found only 2.4% mortality in the unexplained group, another around 7% over 5 years, mostly from unrelated causes.
So the fever itself, if unexplained, isn't necessarily sinister long-term.
Often not. Overall, FUO mortality has dropped significantly, and prognosis really depends on the underlying cause if one is eventually found. If not found, the outlook is often reassuring.
Wow, that was an incredibly thorough journey through FUO, definition, causes, the whole diagnostic pathway, treatment nuances, really getting into the weeds to master it.
It absolutely requires that level of detail, and a classic example of complex clinical reasoning. Now, shall we pivot to our second deep dive topic, syncope?
Yes, let's tackle syncope or fainting, another common symptom that requires careful evaluation. So first off, syncope isn't just any loss of consciousness, is it?
No, it's very specific. The sources define syncope precisely as a transient, self-limited loss of consciousness that's caused by an acute global impairment of blood flow to the brain.
Key features.
Rapid onset comes on quickly, brief duration doesn't last long, and spontaneous, complete recovery, the person comes back to normal on their own without lingering neurological deficits.
So you have to distinguish it from other things that cause transient LOC.
Absolutely crucial. The sources list the main mimics to differentiate: seizures, vertebrobasilar ischemia, like a mini stroke at the back of the brain, severe hypoxemia, so very low blood oxygen, and hypoglycemia, low blood sugar. Different causes, different workups.
Do people usually get a warning before they faint?
Often, yes,
Yeah.
though not always. A syncopal prodrome or presyncope is common. That feeling of lightheadedness, maybe dizziness, weakness, fatigue, sometimes visual changes like tunnel vision or hearing changes just before passing out.
How do the sources categorize the underlying causes of true syncope?
They group them into three main buckets based on the mechanism: neurally mediated syncope, orthostatic hypotension, and cardiac syncope.
Can you quickly explain the difference between those mechanisms?
Sure. Neurally mediated, often called reflex or vasovagal syncope, is basically a temporary glitch in the body's cardiovascular reflexes. Leads to sudden vasodilation, loss of vascular tone, maybe a drop in heart rate. Essentially, the system that maintains blood pressure transiently fails.
Okay, a temporary reflex issue. Orthostatic.
Orthostatic hypotension is a chronic failure of those same reflexes, usually due to an underlying problem with the autonomic nervous system. The body just can't compensate properly when standing up.
And cardiac syncope.
That's different again. It's caused by a problem with the heart itself, either an electrical issue, an arrhythmia, like a rhythm that's too fast or too slow, or a structural problem, like severe valve disease or heart muscle disease, that physically obstructs blood flow out of the heart.
And knowing which bucket it falls into is critical.
Absolutely fundamental. The mechanism dictates the seriousness, the investigation, the treatment, and importantly, the prognosis.
How common is syncope? Does it affect certain age groups more?
It's incredibly common. Accounts for about 3% of ER visits, 1% of hospital admissions. Big healthcare costs maybe $2.4 billion a year in the U.S., lifetime risk. Up to 35% of people might faint at some point.
Wow. Is there an age pattern?
Yes, a clear bimodal distribution. A big peak in younger people, say 10 to 30 years old. Median around 15. That's almost always neurally mediated syncope, the common faint.
Often triggered by something.
Yeah, fear, pain, prolonged standing, heat exposure. Then the incidence drops, but rises sharply again after age 70.
And do the causes vary by age too?
They do. Neurally mediated is most common overall, more in women, often a family history in the young. Orthostatic hypotension becomes much more common with age. Factors include aging changes in reflexes, stiffer vessels, reduced fluid intake, and critically, medications, loss of drugs older adults take affect blood pressure. It's especially common in institutionalized elderly.
In cardiac causes.
Cardiac syncope also increases significantly with age. More common in men, strongly linked to known heart disease or risk factors.
Which brings us back to why figuring out the cause is so vital, the prognosis.
This is really the crux of the evaluation. The sources are emphatic. If syncope is due to a non-cardiac cause, or if it remains unexplained after a thorough workup in a young person where heart issues are ruled out, the prognosis is generally excellent. Life expectancy isn't typically affected.
But if it is cardiac?
That's the danger zone. Syncope, due to a cardiac cause, structural or arrhythmic, carries a significantly increased risk of sudden cardiac death and higher overall mortality. Similarly, syncope from orthostatic hypotension, especially in older folks with other health problems, is also linked to increased mortality.
So the evaluation is fundamentally about finding those high-risk cardiac patients. Let's talk physiology. Why does simply standing up pose such a challenge?
The upright posture is the key stressor, as the sources explain. Most syncope happens when standing. When you stand, gravity pulls blood downwards. About 500 to 1,000 millivol, a significant volume, pools in the veins below your diaphragm legs, buttocks, abdominal circulation.
That's a lot less blood getting back to the heart and brain.
Exactly. It reduces venous return so the heart fills less, cardiac output drops, and blood pressure starts to fall. Your body should compensate instantly. Baroreceptors, pressure sensors in your neck arteries and aorta detect the drop.
And trigger a response.
Yes, they trigger the sympathetic nervous system to ramp up and the vagal system to back off. This should tighten peripheral blood vessels, increase venous return, boost heart rate and contractility, all to counteract the pressure drop and keep blood flowing to the brain.
Syncope is when that compensation fails.
Precisely. Either it fails chronically, like in orthostatic hypotension, or it fails transiently and inappropriately, like in neurally mediated syncope. The result is severe hypotension, the pressure plummets, and you get global cerebral hypoperfusion, not enough blood flow to the entire brain.
A failure of the brain's own blood flow regulation, too.
Yes, it overwhelms the brain's autoregulation. The brain tries to maintain steady flow despite pressure changes, but these mechanisms have a slight delay, maybe 5–10 seconds. If the pressure drop is too fast or too deep, autoregulation fails, and consciousness is lost.
Given the potential danger of a cardiac cause, the evaluation needs to zero in on identifying those red flags. What are the specific high-risk features listed in the sources that scream potential cardiac cause?
This is absolutely central to the initial syncope workup. Table 21-1 in the source material lays out these critical warning signs very clearly. Finding any of these means you need to think cardiac first.
Let's run through that list. What flags a potentially dangerous heart issue?
Okay, high-risk features include chest pain suggesting coronary ischemia, heart attack related, any signs or symptoms of congestive heart failure, known moderate or severe heart valve disease, known moderate or severe structural heart muscle disease, ECG findings suggesting ischemia or prior damage.
Specific ECG abnormalities, too.
Yes. A significantly prolonged QT interval, the sources use 500 milliseconds as a marker for arrhythmia risk. Repetitive pauses from the sinus node, or long sinus pauses, persistent, unexpected slow heart rate, sinus bradycardia, certain electrical conduction blocks like bi- or trifascicular block, or a wide QRS complex, 120 meters, suggesting problems with the heart's wiring.
Other red flags.
Atrial fibrillation, episodes of non-sustained ventricular tachycardia, a family history of sudden unexplained death. ECG evidence of pre-excitation syndromes like WPW, the specific Brugada pattern on ECG, experiencing palpitations right at the time of fainting, and a really big one, syncope that happens without warning while resting or specifically during physical exertion. Exertional syncope is a major red flag for a cardiac cause.
That's a comprehensive list. Finding any one of those really shifts the focus towards a cardiac workup, doesn't it?
Immediately. It signals the potential for a serious underlying heart condition that needs urgent investigation and possibly intervention.
We have covered an immense amount today, really digging deep into two areas that demand sharp diagnostic skills. From the detailed breakdown of fever of unknown origin, the definition, the shifting causes, that systematic investigation involving PDCs and PTCT, the cautions on treatment right through to unpacking syncope, its precise definition, the physiology of maintaining consciousness, and the absolute necessity of spotting those cardiac red flags.
Both topics really showcase the body's intricacies and the challenge of clinical investigation, don't they? They highlight how essential that methodical process is: meticulous history, careful examination, structured testing, understanding the why behind the symptoms.
And recognizing common things, presenting weirdly, using advanced tools appropriately, and even knowing when to pause and reassess. It really drives home the level of understanding needed to master these areas.
It does. It's about connecting the dots between symptoms, physiology, and potential pathology in a very disciplined way.
So as we wrap up this deep dive, here's something to think about. How fascinating is it that seemingly straightforward symptoms, a fever that won't quit, or briefly passing out, can be the presenting sign for such an incredibly diverse range of conditions? From hidden infections and complex inflammatory states to serious heart rhythm problems or autonomic failure.
It truly underscores how interconnected everything is within the body and how subtle signs can point to profound underlying issues. It's the continuous challenge and reward of diagnostic medicine.
A perfect encapsulation. Thank you for joining us on this intensive exploration. We hope this detailed walkthrough has genuinely deepened your understanding and brought you closer to that mastery of complex medical information we strive for here. Keep digging, keep learning, keep questioning.
Until next time.